Welcome, everyone, to this episode of the Sunflower Palliative Care Podcast. This is a podcast exploring all aspects of children's palliative care around the world. This was a podcast we started to engage and learn from each other from our international colleagues in pediatric palliative care. We have a really big, amazing community from all around the world, and this is a podcast where we hope to connect all of us a little bit closer. These podcasts are here so we can share, learn from each other, hear each other's stories, and inspire each other to continue doing this hard work. I'm Natasha Datu. I'm a volunteer with Two Worlds Cancer Collaboration. I'm a pediatric oncologist at BC Children's Hospital in Vancouver, Canada, as well as a pediatric palliative care specialist at Canuck Place Children's Hospice. In 2023, the Sunflower Children's Network, alongside various other participants and supporters, started a leadership program that brings together young and inspiring healthcare professionals who are engaged and wanting to provide pediatric palliative care in South and Southeast Asia. Today, we're starting a series of 4 podcasts where I will be talking with some of our pediatric palliative care leadership program graduates and participants about some of the really incredible initiatives they are starting in their home countries and communities. So today we are talking with our first of 4 participants who will share her experience in the leadership program as well as her project, Dr. Archana Ilangar, who works in Hyderabad, India. Welcome, Dr. Archana. Maybe you can tell us about yourself and where you work.
Yeah, thank you, Natasha. So I'm Archana Iyengar, and I've been a general pediatrician practicing for 18 years. And after which I did my fellowship in pediatric palliative care under Two Worlds Cancer Collaboration and PRPCS Hyderabad. And now I'm working as a pediatric palliative care consultant in Hyderabad, and I take care of children with palliative care needs, with cancer, non-cancer, in hospital, at homes, and also in the hospice.
Thank you, Archana. And as someone who has had the privilege of visiting my Hyderabad colleagues, I know it is a busy, busy place for you all, and you have done such an amazing job of disseminating this pediatric palliative care approach and caring for all these children. So I just wanted to say thank you for joining us. I'm so excited to hear about your project. So my first question, I wanted to know, why did you want to participate in the Children's Palliative Care Leadership Program? What inspired you to join that last year?
Yeah, and Natasha, so if it is one word that I can say what inspired me, it is all what I saw and experienced as I did my fellowship under Professor Dr. Gayatri Palat, who's been a great inspiration, my mentor and guide. So in this 1 year, as I did my fellowship, I definitely learned pediatric palliative care. And the end of 1 year, I was confident enough to take care of a child with palliative care needs. But I always admired and saw how my different teams in the different programs would work in sync, and with different team members having different kinds of strengths and weakness, but finally they all just gathered up with one mission to help a child in distress. And these all these teams were headed by Dr. Gayatri Palat. So I saw an exemplary leader in her, and I was wondering how I can inspire my team too, because I realized that being a good leader will not only help in giving better care for the child and family, but also it would definitely help in expanding the services in case any in the near future.
Thank you so much for sharing. And you're so right. Dr. Gayatri is such an inspiration, I think, to all of us. And how lucky, right, that we get to kind of continue to learn from each other, and a really profound way of explaining sort of not only providing pediatric palliative care, but how do we, now that we've established such a great program in Hyderabad, how do we expand and become leaders in this field? Because I think it matters to continue to disseminate, to continue to inspire others on how to build these programs. So early on in the program, um, there was an in-person workshop in Hyderabad where the leadership scholars and faculty gathered in India, which I'm sure you were participating in. Um, what do you think? What was kind of a particular memorable moment or parts of this program for you, with everyone gathering together in person? What do you remember most about that?
It was a really good 48-hour gathering what we had, because I met various professionals from healthcare in different fields and from different parts of India and also different parts of the world. However, I realized that everybody there came with a very, very common vision and passion of pediatric palliative care. And it was so nice that each one could share their experience of what they are doing and what they wanted to do just to create a better world for the children in need and who are suffering. So the most memorable things for me was I learned a lot from the very experienced faculty about leadership, which was very much new to me being a leader. So a lot of aspects of being a good leader I came to know in the leadership course, and the interaction what we had with my fellow colleagues, that was also very, very good.
Thank you for sharing that. And it sounds like there were so many people there from various parts of the world. Can you just remind me a little bit about some of the people who were there and what parts of the world they came from?
Yeah, we had faculty from St. Jude's. We had faculty from, I think, Stanford, and we had faculty from India too, and also from the Gulf. And the other fellow colleagues again were from Bangladesh. They were from Philippines. They were from different parts of India and Sri Lanka. So it was like just one big family with a one common aim of doing better for children in who suffered. So we had a good 48-hour of experiencing, sharing, and learning everything about doing better pediatric palliative care.
I love that. One big family with a common aim of doing better for children. I think that should be our new motto.
Yes,
I
yes.
love that. um, can you tell me maybe what was one of the most surprising things that you learned with all of this wealth of knowledge? What surprised you?
So I really didn't know much what makes it into becoming a good leader. It was just that I used to think, okay, fine, one person dictates and then the others have to follow. But it was much, much beyond that. And it really, it is not that overnight one can become a leader. There's so much to learn, especially about the team dynamics, about the emotional intelligence, and about different practices of becoming a good leader. All these things really surprised me that if we could follow or to an extent, then definitely we could be on the right path and have a better team, which also would look up to us.
Interesting. That's really helpful. I think that's so true, right? Being a leader, I think one of the main things when I think about good leaders that I've had as mentors and teachers, they continue to learn, right? I think a mentor
Yes.
also is open to growth and open to learning as they progress in their career and leading their team. And I think pediatric palliative care is one of those fields where we all continue to learn from each other, right? Especially as we interact with colleagues in different parts of the world, we learn and we grow every day. So I think I totally agree. I think that is a really big part of growing your leadership. So every leadership scholar, which you are one of our first scholars, has to develop and conduct a project. So can you tell us a little bit about your project, Archana?
Yes. So I wanted to start this project connected to perinatal palliative care. I work in a hospital, non-cancer children's hospital for women and children, which is 2,400 bedded hospital, and they have a monthly delivery of around 1,000 babies. So when I was doing pediatric palliative care and neonatal palliative care, I came across parents who many a times asked me, what if we would have known that my wife had an anomaly earlier? So would the journey would have been different? Would our stress levels would have been different? Maybe would we have got different kind of support? This was one instance. And also when I came across a parent who said our baby did live but lived for a few minutes, and we really didn't know what happened to the baby after that. We were not even allowed to hold the baby, and there was no dignity absolutely, because the baby was not going to live. So these two instances made me feel that yes, what if I would have given our support from palliative care, extended it to antenatal, and then made their journey more comfortable and help them more in their unfortunate journey of having a fetal anomaly, which is life threatening. So then I thought definitely we can start this perinatal palliative care project. and then we can do better for the parents in need.
Wow, thank you for sharing that. I mean, I think the story of the parents who weren't prepared for their child to only live a few minutes and felt they weren't allowed to hold their baby, they weren't feeling like the baby's life had dignity is so profound and so meaningful, right? I think
Yes,
in these moments, especially if the child is only going to live a few minutes, those are so much more precious in a way. And you know, having a system and having the support of a care team to maybe allow families to hold their baby, explain to them what might happen ahead of time, and give them those supports, I think will change many lives and give many babies dignity, right? As they live
yes,
even
very
for a
true.
short time. So, wow, that is incredible. And, with how busy your hospital is, a very big feat. So I commend you for this because I think it is big work. It's very
Thank you.
impressive. So how do you think that your project fits in with your vision of children's palliative care in your country as a whole?
Pediatric palliative care in India was pioneered by Professor Dr. Gayatri Palat, and I feel that since we have started this perinatal, we have extended it to perinatal palliative care too. I wish that this becomes a role model, and over this project, I will be able to get a policy and guidelines for perinatal palliative care and embed it in the pediatric palliative care in the country. They are already aware of pediatric palliative care more for children with cancer, but now slowly the awareness is increasing for children with non-cancer, and soon I think even the perinatal palliative care, once integrated with the pediatric palliative care, it will be only an added feather to the pediatric palliative care hat, and probably it will be just one complete pediatric palliative care from the womb till the adolescent, so we can cover the entire spectrum of antenatal to adolescent families and children who are in need of palliative care.
Thank you for sharing that. It's so true that the idea of pediatric palliative care to provide holistic care to families and children, I absolutely agree, should include from the womb onwards. So I like that. I work in a center where we do support antenatal planning and pediatric palliative care for babies with anomalies and who may not survive into adulthood. And I can tell you that caring for those mothers and fathers and the little babies when they're born, especially if we think time is going to be very short, is probably some of the most rewarding work we get to do. So I am so inspired that you guys and your team are taking this on. Can you tell us a little bit about where things are at with your project and your planning, and what have been some of the successes with the project so far?
So initially, we started sensitizing the Department of Obstetrics and Gynecology, who would be the main stakeholders in this project, and then we networked with the neonatologists. And since I started the project and the academic sessions for them in May, we now have 58 referrals from the Department of Obstetrics and Gynecology. In among whom I think we have almost 48 mothers have already delivered, and 10 mothers are yet to deliver. Among them, many of the babies were given symptom management, care in terms of symptom management, comfort care, memory making. We have attended the deliveries in the labor room, in the theater too, and given the family also a lot of support when it was required. In terms of success, I think the continued referrals from the obstetric team, where they write and send that to the pediatric palliative care, kindly speak to the family, and and we make a birth care plan, and then again discuss it back with the obstetrician, and then again talk to the either the neonatologist or the pediatric surgeon sometimes if it is a life threatening surgical anomaly. So we keep everybody in the loop along with the family, and then a common shared decision is taken many a times with the parents or with the extended family. So what best would be planned for the mother and for the baby. Another part of success what I felt was we are getting a lot of incoming calls from the patients. Almost in these 3 months, each month we have got around 50 calls, maybe 20 to 22 calls per family, but they call repeatedly because once they have known that there is somebody to fall upon who give support. They call us for many things whenever the mother is not doing really good. And then we try to coordinate with the gynecologist and then further take it on like that. So, and even after once they lose the baby, the families have come back to us, and we also have done bereavement calls, and the family feels very, very comfortable to come and talk to us even after they have lost the baby after birth. We are also in constant calls with the families whose babies are surviving, probably for weeks to months, and also have done a lot of memory making when they requested. So we also felt that they understood what type of care we are able to provide, and they also felt probably much benefited from the support they got.
Wow, it's incredible how much work you've been able to do in such a short period of time with, with your small team. So, um, I think you're already making such a big difference in so many lives. So, congratulations to you on this. This is big. Can you maybe just walk our listeners through exactly what would happen if you get a referral, you go talk to the family, and they've chosen a comfort focused approach to their baby's care? Um, how you would support that after the baby was born, and kind of what memory making is, just so we know what that feels like. Mhm.
Yeah, so, for an example, we had a referral saying that the mother had a fetus with hypoplastic vermis and pons, and they had continued the pregnancy because they were a little beyond the age of termination. So then we had supported them from 28 weeks of gestation, and when the mother came in again for the delivery. During that time, we had multiple sessions of counseling with the parents, with the grandparents, and told them that maybe your baby will not have a normal lifespan. The baby might have neurological symptoms because of the hypoplastic pons and hypoplastic vermis. And even the baby might survive probably for hours to weeks in case depending on the development of the pons. So there was a antenatal scan which showed the findings up to a certain limit. So we told them that once a baby is born, we can give you further details. And then we told them that we will be there during the delivery of the baby. In case, depending on the condition of the baby, if we feel the baby is not going to really live long, then we'll directly give the baby into your arms, and then you can hold the baby as long as the baby is there. But if the baby has good signs of life, then we would coordinate with the neonatologist and then shift the baby to the NICU. Simultaneously, we also coordinated with the neonatologist. And when this baby was born, the baby had a good cry, and the baby had a good weight also. So this baby was delivered by cesarean section. So we were in the theater, and then we took the baby and we went to the NICU, and the baby was just given comfort care in the NICU in terms of warmth. Symptom wise, the baby had continuous shaking movements non-stop, literally involving the legs and hands and head. So, and the baby also had a microcephaly. So when the parent father came and the grandmother came to see the baby, they were so much in distress seeing the shaking movement. So then we discussed with the neonatologist, and then they said, no, we won't put any cannula, because they didn't want any aggressive measures for the baby to go through. So we gave the baby intra-oral injection midazolam. Orally, we gave the baby that, and then slowly shifted to clonazepam, that is benzodiazepines for this symptom management. And then slowly the symptoms definitely subsided over the next 3 to 5 days. And then we told them that maybe the baby would have the symptoms now less, but it can always increase, and the baby could have irregular respirations at any time because of the underdeveloped pons. The mother, because she underwent section for a few days, she was not able to come and stay with the baby. Then we told her that you need to give time to the baby, because we don't know how long the baby can survive. Okay, so after giving midazolam and then shifting it to oral clonazepam, then the baby's symptoms were much less. And because the baby was in less distress, the parents were in so much less distress. And the parents wanted to just spend a lot of time with the baby, but not in the NICU with the monitors and that ambience. So we shifted this baby along with the parents and grandparents to hospice, where they spent a week. And the mother learned how to take care of this small, gentle baby with microcephaly and tremors. Of course, they were very less. In this time, they also, according to their culture and practices, they wanted to do some memory making in terms of naming, dressing the baby, and taking footprints So we just did what they wanted to. After that, there was a very beautiful transition of care from the hospice to home, wherein our team went and saw this baby at home also. So there were 2 to 3 visits at home, and then this baby was shifted to the district of Telangana of our state, wherein also we have this palliative care centers. And from there, the team went and visited them and then did video calls to us. So the baby is now 2.5 months old, very comfortable, that the baby is not in distress. They, however, know that the baby will not be having a normal lifespan like the other babies and any time might just progress into apnea. But they say that we had given them enough support and they really understood what the problem the baby has and they have now accepted the same. So I think they are at more peace now.
Wow, that is a beautiful story of how your team was able to integrate kind of this antenatal, perinatal, pediatric palliative care support, and then surprisingly, the baby did well and is still alive, and you were able to support not only the symptoms but the family's emotional needs on how to care for their baby differently, right?
Yes.
And in the home. So how you've integrated kind of all of your programs to support this family. So what an incredible story. Thank you for sharing.
Had such babies, and we also had babies who were like lived maybe for 2.5 minutes, 2.5 hours, and few hours in the a few minutes in the theater and labor room and in the NICU later. So similarly, we did bereavement support. We gave bereavement support for these parents also, and in the limited time they had, we just did what they wanted. So it was a spectrum of different problems and different systems involved. Of course, we have taken a data of for the statistics purpose to see what are the major systems involved, from what referrals what we got. But yeah, I think we have come this far in the past 3 months, and definitely we should go much ahead in the coming days.
You've done a lot in 3 months. I think the other thing that I was thinking about as you were sharing your stories is how you've now been able to also reach different departments, right? The obstetrics department, the neonatologists, the general surgeons, right? So been able to expose all of these other departments who take care of children with serious illnesses to pediatric palliative care and what the service can provide. So it's also a way for you to kind of expand healthcare professionals understanding and knowledge of pediatric palliative care. Can you tell me one thing that has surprised you so far about the project?
So, when I started the project, I knew my main people of contact and dependence would be the obstetrics and gynecologists. So, I thought maybe it would be a little difficult to approach them because they are always on the move. They always are. I really admire them because they always, at any point of time, they're the only physicians who deal with 2 lives for 9 months. The whole responsibility of 2 lives is taken upon them. So, I thought if I go and introduce now this something new, which they were not very they were not exposed to. Many of them were aware probably, but they were not exposed to really in practice. So I was not sure if they would really want our help because they are so immersed in their own practice and busy schedule. But I was very, very happy with the warm welcome from the gynecologists. And what they did was they immediately were so ready to take up what we wanted to provide them. And they included us in their WhatsApp groups so that they will keep referring whenever they came across an anomaly, life-threatening anomaly of a mother, either in the OP or in the IP. And even after that, whenever we used to go on rounds in their wards, we always had a very warm welcome in the wards also. And they gave us all the freedom to talk to the mother and family. And many a times I felt they also, depending on their decision for termination, they used to tell right on that once you come back after consulting the pediatric palliative care PNPC, we named it as perinatal palliative care team, then we can take a call or we can again discuss. So I didn't expect this easy and so friendly approach from the gynecology team because usually this was very new to the hospital where I work.
And a whole different,
Yes.
philosophy of how to care for these babies and these families. So, wow, that's
We
amazing.
also got
That's a great surprise.
yes, we also got permission to enter the labor room and the theater when in need. And they used to be for few mothers who didn't really want to go ahead for a section because they were carrying a baby with an anomaly, and there were a little controversy whether it should be a normal labor or a cesarean section. Even then, when we went and spoke to the doctors, I mean the gynecologists, they really cooperated so much and helped us in deciding what was best and what the parent and the family wanted. So at no point I thought that, oh, like what I thought would be difficult with this department, it was not so. So that really surprised me.
Wow, that's great. Especially how welcoming it sounds like they have
Yes.
been into the theater and integrating kind of collaborative care that you've been able
And
to
the
do with their department.
other part, maybe even for the families, it was something new because we started talking to them about death even before the baby was born. So I thought how the parents would take it. But we realized that that kind of counseling and that kind of support really helped them. And that I could make out with the number of calls that we get once we registered them. And they, many of them who came back after they lost the baby just to come and, went out and share their emotions with us. That also surprised me because everything was very new in this field. Of course, pediatric and neonatal palliative care was already going on, but this was something new. So it was a pleasant surprise in both ways.
That's beautiful. That's amazing that people have been so welcoming to this approach. So, is there anything else before we wrap up that you'd like to share with us about your project, what you've learned, anything?
Few challenges that maybe we face because we provide palliative care services only restricted to 9 to 5 in the evening, and in this field of obstetric and gynecology, many a times they cannot really plan the delivery. So I
Mhm.
feel that in case we have a team who's there round the clock, then every delivery, whether it's emergency or a planned emergency section or a planned labor or an induced labor, every time we can be there to give our perinatal palliative care and comfort care to the baby in need. Now we are just able to give the families support during the delivery time only if it happens in our working hours. So I feel that is one challenge for us that we need to overcome by having a team who will be working 24 by 7 in the hospital. So we need more manpower, and also maybe we would it would be nice if we have a small corner, palliative care corner, where now we bring the babies who are not admitted into the NICU but who live for a few hours. We bring them to our room where we just make the family feel comfortable because we don't have a designated palliative care corner for these babies who are born. So either they have to go home or they have to be in the NICU, but not in
Mm.
between. So maybe if we have a designated palliative care corner where for such babies, then there is privacy and there is a lot of space for emotions, and I think we can do much better care for the families.
Right. So those are some things that hopefully you guys can work on in the future.
Yes,
Well, thank you so much, Dr. Archana, for sharing such an inspiring project. I am in awe of you and your team and
thank you,
everything you've
Krishna.
accomplished in these few months. Thank you for sharing that with us today, and I so look forward to seeing all of the things that you will accomplish in supporting these families and babies with comfort approaches. So thank you again so much. And thank you for listening. Join us again next time for another one of our Inspiring Leadership Scholars projects, where we hear a different story of how we are changing the lives of children and families living with serious illness through pediatric palliative care. These podcasts grew from the seed of an idea as we talked with our colleagues in the Sunflower Children's Network. The Sunflower Children's Network is an initiative of Two Worlds Cancer Collaboration, focusing on children's palliative care. We hope to build a world where no child suffers from serious, life-threatening illnesses. To learn more or to donate, please visit twoworldscancer.ca. Thanks, and see you next time.